So in this session, I'll be discussing about a syndrome, which is one of the complication of common bile duct stones. Okay, that is Merizi syndrome. So what's written that it's written that a complicated gallstone disease resulting from compression of common hepatic duct by the stone chronically impacted in the neck of the gallbladder. So what is it trying to tell us is it's a complicated gallstone disease. It's a gallstone disease resulting from compression of common hepatic duct. So if you look into this point here, this is a gallbladder. This is a fundus of the gallbladder. This is the body. This is an infundibulum. This is a neck. This is a cystic duct. Between the neck and the cystic duct, you have a pouch known as Hartmann's pouch. Right? This is a cystic duct. This is a common hepatic duct. Now, what happens in this Merizi syndrome is this is a complication of a gallbladder disease. Okay. Now, the stone in the gallbladder, what does it do? It compresses the hepatic duct. What is it? It compresses the hepatic duct. This is a compress. It compresses the hepatic duct, common hepatic duct. And this compression of the common hepatic duct by the stone, and this is chronically impacted in the neck of the gallbladder. So now the stone which is present in the Hartmann's pouch, that is between the neck and the cystic duct, this later on compresses the common hepatic duct. So ultimately, it's a complicated gallstone disease resulting from compression of common hepatic duct by the stone chronically impacted in the neck of the gallbladder. Now let us look into the pathogenesis here, how it acts and how it is present. In the pathogenesis, and if you observe carefully, you have something known as impacted stone. Now, the stone which is present in the Hartmann's pouch, what all it can complicate? So you can have something known as chronic pericholecystic inflammation, or you have an external compression of common hepatic duct. The stone which is trapped in the Hartmann's pouch between the neck and the cystic duct, it can, because of the block, the bile juice or the bile ducts, okay, the bile acids which is present in the gallbladder is not passing into the cystic duct, later into the common hepatic duct. There is an accumulation of that in the gallbladder. So there is an inflammation around the cyst, that is cholecyst, that is chronic, and this is chronic pericholecystic inflammation. So there is inflammation here. There is inflammation. Now, if a patient has an inflammation here, there will be a problem. What happens? Now, this is the gallbladder. This is a common hepatic duct, right? This is cystic duct. This is the cystic artery. And you have got a triangle known as, which triangle is? Calot's triangle. Now what happens here is there is an extensive fibrosis in Calot's triangle. Why there is an extensive fibrosis in the Calot's triangle? Because there is an inflammation around the gallbladder. This inflammation leads to the fibrosis in the triangle, right? Leads to the fibrosis of the triangle. So this is the fibrosis in the Calot's triangle. That's what you need to understand. This pericholecystic inflammation can also have a stricture here. Right? Can also have a stricture here, or it can have a stricture at the biliary apparatus, right? Now, what happens here is in the in a chronic pericholic inflammation, the patient can have an extensive fibrosis in the Calot's triangle. The patient can have a stricture here. Now, what happens in the next important aspect? What happens here is the impacted stone which is present, right? The impacted stone which is present in the Hartmann's pouch. What does it do? It compresses the common hepatic duct. So that's what you need to understand. This is what it compresses the common hepatic duct. When it compresses the common hepatic duct, now it can have a problem. So what's the problem here? The problem is there is a pressure necrosis of intervening bile duct wall. So the gallstone which is present in the Hartmann's pouch, right? Hartmann's pouch. This can compress. It can compress the common hepatic duct. This is a common hepatic duct. What is it? This is the common hepatic duct. It compresses the common hepatic duct. Now once it compresses the common hepatic duct, remember that there can be a pressure necrosis. There can be a pressure necrosis because of a compression of what? Of a bile duct, right? There can be a pressure necrosis of a common of a bile duct wall. They can compression here. There is a necrosis here. Now, once if there is a necrosis, what happens if there is a necrosis here? There is a fistula between the gallbladder and the bile duct. Now there is a fistula, so that we call that as cholecysto, right? Choledoco fistula. What do you mean by choledoco? Cholecysto means, what is cholecysto? Cholecysto is a gallbladder. What is choledoco? Choledoco is a bile duct. Now there is a fistula, right? There is a compression between the gallbladder. Remember, you can observe here, between the gallbladder, and there can be a compression between the gallbladder and the bile duct, right? This is a common bile duct. So there is a fistula between the gallbladder and the bile duct. So we call that as choledoco fistula. Right. Now, either because of chronic pericholecystic inflammation or external compression of common hepatic duct. Now what happens? There will be an biliary obstruction, right? Biliary obstruction. The flow of the bile, it's improper, right? Reduced, leads to further complication and the symptoms. But the important point which we need to understand, we have a classification here. The classification is McSherry's classification and Sanders classification. In the McSherry's classification, you have two types. One is type 2, one is type 1, and the one is type 2. Type 1 is a no fistula between the gallbladder and the bile duct. In the type 2 scenarios, there is a fistula. You have another classification known as Sense classification. You're sending her, Sherry, okay, McSherry and Sense. In the type 1, type 2, type 3, and type 4. So send us type 1, send us type 2, send us type 3, and type 4. What happens here is, there is an external compression of common hepatic duct. In the type 2, the compression of the common hepatic duct, and this compression is less than 1/3. Remember, less than 1/3. Right? Less than 1/3 destruction of common wall. In the Sense type 3, right? Both are 3. 1/3 to 2/3 destruction of common wall. What is a common wall here? This is the common wall. This is the common wall. In the type 4, more than 2/3 complete destruction of common wall. So remember that you have a type 1, you have a type 2, you have a type 3 and a type 4, guys. In the type 1, what happens? There is an external compression of common hepatic duct. Next you have less than 1/3 destruction of common wall. A 1/3 to 2/3 destruction of common wall. And 3, more than 2/3 destruction of common wall. Right. So these are the basic classification which we need to understand. In McSherry's, type 1, there is no fistula. Type 2, there is a fistula. Right. Now let us understand how the patient presents with. There is an obstruction. So it's very simple here. There is a related attacks of cholecystitis, cholangitis. There can be an obstructive jaundice. There is a symptomatic patient can also have. How do you, in the evaluation, we need to rule out the CA gallbladder, right? Enterohepatic biliary carcinoma we need to rule out because of an obstruction, right? Now, how do you do that? And the first basics here, you have a CBC, LFT good, and USG abdomen shows there is an initial screening. The USG abdomen initial screening, and this tells me the how much the stone size and number of stone location, and it also tells me the duct status dilatation, how much the dilatation of the duct is, the stone, and it also tells me that IHBRT, right? The intrahepatic biliary, right? A dilatation. And it also tells me the inflammation part, right? So it helps in the initial screening. It tells me the size. It tells me the location. It tells me the ductal dilatation. It tells me IHBRT. What is ERCP, guys? The ERCP as a part of evaluation of obstructive jaundice. That is what you need to understand, right? It is a part of evaluation of obstructive jaundice to rule out or to treat CBD stones. Now, the endoscopic retrograde cholangiopancreatography, what I do, I look into whether the stone is present in the common bile duct, and it also helps me to remove if there is a stone. MRCP, it is necessary for the biliary anatomy. Now, how do you manage these patients? There is this syndrome patients. If there is an extensive Calloch's adhesion fibrosis, what I do is I cannot remove, right? What I do is I open the gallbladder at the Hartmann's pouch. I've told you where the Hartmann's pouch is. And what do? I empty the gallbladder contents. Good. Now I identify the cystic duct opening. Alright. I identify the way the cystic duct is opening from inside. I open. And we need to understand, and I look into the point. I avoid the dissection in the extensive Calloch's triangle, right? I avoid the heavy dissection. And what I do now, I do something known as subtotal cholecystectomy, and this is safe. If a patient has a small fistula, that is a partial cholecystectomy is done. In this partial cholecystectomy, remember that there is a use of gallbladder stump to repair the duct. So that is known as you are using the gallbladder stump choledocoplasty. So this is the choledocoplasty. Choledoco is a CBD, right? Common bile duct. There's a flap here, right? Gallbladder. So that is for the small fistula between the connection of the gallbladder and the bile duct, right? And next we have got something known as more extensive fistula. If there is a more extensive fistula, I do something known as I connect the biliary apparatus, a bile duct, to the I can connect to the intestine. So bilioenteric anastomosis, driven by hepatojejunum. So you can connect that to duodenum. You can connect the biliary, a common bile duct, to the jejunum also, right? It is a more extensive fistula. If there is a more extensive fistula, you do have something known as biliary, right? Biliary enteric anastomosis. A small fistula, you do a flap which is connect flap to the common bile duct. You repair it by use of GB stump. So that is choledocoplasty, right? A subcholecystectomy. It's a safe, guys. It's a safe. And the next important aspect is you have a something known as fenestrating or reconstituting. You have a gallbladder. So I'm talking about the subtotal gallbladder types. Okay. So you have got something known as fenestrating type or reconstructing type. In the fenestrating type, the gallbladder is open. Remember, the gallbladder is open and the stones are removed, guys. The posterior wall is attached to the liver, is left behind, is left behind, is left behind, is left behind. So the posterior wall attached to the liver is left behind. Next, we have got something known as reconstituting. What is reconstituting? In the reconstituting point, what I do is you have got something known as gallbladder amputated remains remaining